day.
But what's the real situation? And that's what we're going to be talking about today. But let's welcome you to the show with today's proverb. Dennis will share, and we'd love to hear your interpretation.
Yeah, our proverb today comes from Togo, now a country that is located between Ghana to the west, Benin to the east, and Burkina Faso to the north, with the Atlantic Ocean to the south. We talk about its economy, and the main exports include phosphates, cotton, coffee, and cocoa. Now, Port of Lome, one of the busiest ports in West Africa, serving as a trade hub for landlocked neighbors. Agriculture is equally huge for propelling the country's economy. Let's go to the proverb. A man does not know he has pepper in his eyes.
Thank you.
How would you define that?
Thank you so much, Dennis. It's a pleasure to be back here, and thank you for the proverb. Indeed, pepper contains a chemical compound known as capsaicin, and which causes adverse irritation when it comes into contact with human tissue or the tissue of any mammal. In this context, I believe that this proverb shows that we should look for red flags and warning signs in any policy or discussions that we have, because they can look very, very attractive and friendly, but ultimately we can experience the pain. And that's why, for instance, Shah looked the solution for everything. But right now, everyone is crying. The cancer patients are not able to access a treatment. And now this is the pain, the pepper that we are experiencing in health financing in Kenya.
Yeah, it's the pepper we always saw, but you never know it was there.
Yeah, absolutely. Yeah.
Oh, interesting. Well,
very interesting.
Well said, yeah.
Indeed. And to be able to look at it like that is then we keep going back and touching our eye with this thing.
Yeah.
But when it seems as though difficult to learn from it. So let's get into the conversation then even from that when we talk about maternal health care, we often just imagine that we're talking about a woman being delivered of her baby. But it would appear as though it covers a span of things. So let's go into what maternal health care actually is before we look at the state of that care in Kenya.
Well, thank you indeed for bringing the voice of women upon this table for discussion. And maternal health care, in my view, refers to the comprehensive health and well-being of a woman at the time of pregnancy, during child delivery, and also the postpartum period. It involves such measures like antenatal coverage, so that women are able to seek ANC coverage, issues like skilled birth attendance, with a view of ensuring that every pregnant woman and girl can get the best possible maternal outcomes.
Okay. And so what is the state of it in Kenya today? Every woman and girl. This is interesting because just last week we looked at, numbers of girls in a couple of counties who are getting pregnant below even maturity, in terms of physiological maturity. So if we're looking at girls in the hundreds of thousands, their bodies are not fully developed. And here they are going through a condition which essentially is physiologically altering, as well as there's a lot of burden, literally, and that's why you have to be delivered of a baby. So we have girls who are underdeveloped, who are getting pregnant, having children, who need this care as well. I mean, it goes across board. What is the state of this particular healthcare? Also taking into consideration that postpartum hemorrhage is the number one killer of women in this maternal space.
Maternal health care is a priority in sustainable development, and that is why the Sustainable Development Goal 3.1 seeks to lower maternal mortality rate to less than 70 deaths per 100,000 live births. And in the world today, it is estimated that up to 6,000 women die every day, and the statistics further show that a woman dies every 2 minutes in the world. And right here in Kenya, it is estimated that about 6,000 women die annually due to maternal causes, and the maternal mortality ratio in Kenya today is estimated at 355 deaths per 100,000 live births, which shows that Kenya lags behind in the fulfillment of the SDG 3.1. And this is really a worrying trend. There are many causes of maternal deaths in Kenya, and the leading cause, of course, is the postpartum hemorrhage, which is basically the bleeding that women can suffer during childbirth within 24 hours, and also up to 6 weeks. And we have lost many women to this condition. And also there is preeclampsia and also eclampsia, which is basically hypertensive disorders. And I have to say that these conditions that is causing high mortality among our women are preventable, and I call on the state to take concrete steps to address maternal mortality. We cannot afford to continue losing women. Pregnancy should never be a life-threatening situation in this country.
Dr. Hari, as we talk about the state and policies in place, a lot has been put in place, right? But all these policies require funding. All these require equipment and resources that will give this policy life, right? Yeah. You look at previous statistics, and Kenya was doing really well in terms of addressing maternal mortality in the country. But over time, we find that we are going back. We are stepping back into the old days when maternal mortality was going high. So in terms of the government just ensuring that we achieve the goals that we have set, what needs to be done? Because every other time you'll find when you talk about PPH, the equipment that would help to deal with this matter as an emergency response are not there. Is it that we do not know? Is it that we are not taking such matters seriously? But then again, what must we do to remedy the situation?
I think it is very, very important to remind the people of Kenya that from 1963, when we attained independence, up to 1990, the per capita income in Kenya was higher than China. And during this period, our public hospitals, our public schools were the best. Every Kenyan wanted to attend a school. Every Kenyan wanted to go to a public hospital. But look where we are at this moment. From 1990, our public schools, our public hospitals have continued to decline in terms of service delivery. So where have we gone wrong? Now, back to your question, health financing is a priority if we want to improve our Human Development Index. Now, if you compare what happens at the global scene, especially in the global north, you do realize that countries like Sweden and Germany and Switzerland and so forth that have managed to reduce maternal mortality rate to at least 4 deaths per 100,000 live births. They have invested heavily on healthcare. A country like Germany, for instance, allocates 12.11% of their GDP to finance healthcare. Now, look at what Kenya spends. It's only 4.3% of the GDP for health financing, and out of this 4.3% of GDP, nearly half is from private insurance and out-of-pocket payments. And therefore, I would wish to say that where we have gone wrong is in terms of underfunding of health in this country. Now, a lot has been said about investment in health facilities, and of course, since devolution, we have seen facilities increasing and so on. But the question is, are these facilities first properly equipped to manage obstetric emergencies? Number two, do we have skilled, properly motivated healthcare workers that can take care of these emergencies? It is indeed very sad when we see doctors and health workers going on strike because county governments are not able to pay them accordingly. It takes 7 years to train a doctor and a further 5 years for postgraduate studies, and then you find governors, not really taking care of doctors. So we need investment. We need policies that are concrete, and lastly, we need political will. If you look at Tanzania, President Mama Suluhu took upon herself even to call the provincial administrators whenever the rates of maternal mortality goes up, and this has led to a decline in those numbers. We would really call upon our First Lady, Mama Ruto, to take an initiative and lead this process for fighting for maternal health care, the way our former First Lady, Mama Margaret, did in Beyond Zero campaign.
Okay. I want to go back and look at some of these numbers that you talked about. SDG 3, I think it was what you said, to reduce maternal deaths by a certain number, or at least the requirement was that you should have no more than 70,000. Was it 70,000?
70.
To reduce it to 70 deaths per 100,000 live
70
births,
deaths to 100,000 live births.
Yeah.
But then you said that currently Kenya has how many deaths?
It's 355 deaths per 100,000 live births.
That's almost 5 times the, not even recommended. We can't say that there's recommended death, but even maybe the acceptable number because of flaws here and there. So that's 5 times that number. So 355 deaths to every 100,000 live ones, right?
Yes.
And the number that the SDGs say that you should play with is about a fifth of that. What are the reasons behind these deaths? We know that postpartum hemorrhage is the largest one, and we've had conversations around that before. But what interventions would be needed to curb this number that are currently not available in Kenya? Why are so many women dying due to PPH? Why is that happening?
Thank you for your question, and indeed it is the wish of the people of Kenya to see a decline in the number of maternal mortality deaths. Now, first things first, we have to consider the question of health financing. Postpartum hemorrhage is a preventable preventable cause of maternal death, that if we train our health workers properly, they can be able to mitigate it at the health facilities level. We further need an investment in the equipment that we have. For instance, for postpartum hemorrhage, blood transfusion may help to save lives of our women. But if you consider the equipment that you need for blood transfusion, it is not possible to do that in level 1, level 2, and level 3 health facilities in Kenya. Such women have to be referred to level 4, 5, or level 6. And then there is the whole question of a social health insurance. It is indeed sad that we are leaving behind poor women in seeking health care in Kenya. For instance, for a woman to access maternal health care, they have to be registered with SHA. That is for level 1, 2, and 3. And for level 4, their premiums must be up to date. Now, if they are not able to fulfill these requirements, then the result is exclusion from the social health insurance, and this is what is also causing an increase in the number of deaths that we have. But lastly, let me also mention here very, very clearly that the number of births in health facilities have increased in Kenya up to about 80%. However, this has not translated into a decline in the number of deaths. Why? It is because we lack equipments in these hospitals. We have a deficit of medical supplies. You walk into hospital and you find supplies like oxytocin and so on are missing. This is really, really bad. We have to invest in the infrastructure of our facilities, but we also have to invest in the human capital. We need doctors, we need nurses, we need midwives that are properly skilled so that we can bring down these numbers.
You see, Dr. when we talk about healthcare and maternal health for that matter, there is always the question of affordability. You know, because let's look at the entire journey, and you need to have an OBGYN who carries you through. You need antenatal services. You need pretty much the entire ecosystem that will carry you through all the way to safe delivery. But you talk about an OBGYN that you would need to see frequently. That means you need money.
Yeah.
You couple that up with the fact that you go to most public hospitals and these are services that pretty much are not there. It is pretty much difficult for mothers to get these services. We talk about during delivery day and the need for, because of the possibility of bleeding, you need blood to be ready there. But now we look at even policies or decisions that have been made that some of areas where blood we used to go out and say in high schools, the government now says that would not take place, which now speaks to our blood bank and the readiness of our hospitals to have these things are ready. So with everything that is playing around and it being expensive, which way Kenya, which way our mothers, which way maternal health?
Thank you very much, Dennis. First and foremost, health expenditure per capita in Kenya is $90.08 US. This is the most expensive in East and Central Africa. And the World Bank stated clearly that with the expenditure, with the health expenditure per capita of over $90, we would be able to achieve universal health coverage. So the question we ask ourselves: one, why is healthcare expensive in Kenya, and yet we don't see positive health outcomes. This brings us to the question of governance in health financing in Kenya. There is a lot of corruption in health sector, and that is why in many years in Kenya, the MOH, the Ministry of Health, has been seen as a lucrative ministry where the CS and the technocrats working there are cartels getting a lot of money. Look at the scandals at KEMSA and all that. So we have made healthcare to be too expensive for the people of Kenya. And that is why I call on the policymakers, please make healthcare affordable to the people of Kenya. Our legislators should look at our fiscal policies. Why is it that medical supplies all of a sudden have become very, very expensive? But that said, I would wish to call upon women of Kenya and Kenyans at large. Please let us register for SHA. Let us pay our premium so that the social health insurance can have adequate funds. And I also call for good governance in health financing, so that every shilling that Kenyans contribute is accountable for. We get value for it, because I believe that if people of Kenya can pay their premiums and get quality health care, nobody would even run to private hospitals if we can get really value for our money.
That's, it's interesting because, the last couple of days we've been talking about, really just being able to make sure that the health system is working. But I still want to go back to the nitty-gritty of some of this. And one of my questions to you was going to be, do we see, because previously we were told that a lot of births are still taking place in the traditional way. But now what you've told us is that 80% of all the births that are happening in this country are happening in a medical facility at whatever level. So we're going 2, 3, 4. That's the level of facility where 80% of Kenya's mothers are being delivered of their babies, right?
Yeah.
But the problem is that the medical equipment that is required for this to happen is wanting at these facilities. Okay, transfusion, you won't find that at level 2, but you can actually have a baby at a dispensary, right? If everything is normal, women can be in and out in a day or so. You at a level 3, you will not be able to find a transfusion machine in many of the hospitals there. And if we're having younger girls going in to have babies, we already know that physiologically they're not fully developed. Yeah. The chances of obstructive labor then are higher in younger girls. So you would need to have the advanced equipment in order to deliver them of their babies. So because maternal death is not age. So long as you're a mother and there's a maternal death, that's maternal death. Yeah. So it would be interesting to know those that are in policy making, policy intervention, are they aware that level 2, 3, 4s in many cases do not have the requirements to take care of a situation that may get complicated, that would lead to a maternal death? Because we could be here talking about it, but and I know it sounds almost escapist, but if we are not aware of the real situation on the ground, how can we make it better and reduce the number of deaths that we are seeing if folks don't even know that the equipment that's required for a delivery doesn't exist at a number of 2, 3, or 4s?
I would wish to say, without fear of contradiction, that the policy makers are aware of the inadequate equipment that exist in our health facilities from level 1 even to level 6. We really have a system in the government where they take stock of these equipments and supplies and so forth. And that is why we want to call for accountability. We want to call for concrete measures and commitments by the policy makers, so that we can be able to prevent this these deaths. I would also wish to state here that towards the goal to achieve universal health coverage, there are a number of legal frameworks that exist, and one is on the improvement of health facilities, and it gives powers to every health facilities to retain the revenue that they collect in order to improve those very facilities without surrendering the same to the county government. Therefore, I would call for a proper oversight of the public health facilities so that they can use the revenue that is generated by these facilities to improve on the supplies that they have and so on. And also, secondly, it is important to improve the referral system between the different levels of health facilities, so that where there are obstetric emergencies, for instance, then it is very easy to get emergency care, which would lead to a decline in the number of deaths that we see. And I'd also wish to call on the policy makers to be very serious on this issue of maternal mortality. If you look at the Kenya Demographic Health Survey report of 2022, which is very, very important, we should have all the data that we need so that we use scientific evidence for policy making. Do you know that 2022 KDHS survey report has no data on the national maternal mortality ratio? We don't have it.
How does that even happen?
Instead, they ended up providing the subnational rates across the country. Why are they running away from the facts that exist? And these are the policy gaps. And I wonder if women sit at the Bureau of Statistics and seeing all this malpractice happening, and nobody comes up to say no. So the current statistics that we rely on is the 2009 census and also the 2019 census. And you know, deaths and births are registered every day in Kenya. Why can't the government supply this data so that it can be used for policy formulation? Look, for example, at the requirement of SHA registration. You know, Article 43 of the Constitution of Kenya provides for, the highest attainable standard of healthcare. Why must we have a card, a number, to get access to maternal healthcare? And yet, women of Kenya have identification documents recognized by the Constitution. Why can't a woman walk to hospital with her identity card and get maternal health care service? These are the policy gaps that we say we need to fill them, and Kenya needs to respect the rights of women.
But it was happening under Beyond Zero. Women would walk to facilities pregnant to be delivered of babies, and what they had to show was their ID. This happened in Kenya, and it was paid for. And they would have their babies be given a care package at the end of the 2-3 days, however many they stayed in hospital, barring all complications, that they stayed and got this care, a package with the cotton wool that they needed, maybe a few diapers for baby, and, sanitary, care for the mother, a package of salt. Those things happened just about 3-4 years ago in Kenya. And there are people who give us their testimony that actually happened, and they didn't pay a cent for that. How did it happen under that, and why wouldn't that be carried on to now? You're in this space, so do a comparison for us in terms of what happened then and what's happening now. Are women having to pay for this? Can they not walk into a facility and get care with an ID? Why would things change? They told us that they didn't change, they did not end Linda Mama, that what they did was, I can't remember the word that they used, but they tweaked it a little bit for it to be even better. Enhanced, that's the word, enhanced. Is that the case?
Well, I don't think so. There are a lot of gaps in this policy which we want to talk about, and hopefully they will be bridged. Kenya indeed made an effort in the former regime to promote free maternity services, which was later named Linda Mama. And all this were being provided under the former NHIF package, and the state actually met those very, very cost. Now entered SHA into the picture, and we were told that Linda Mama was now enhanced and incorporated into the SHA and so on. Mm-hmm. But now there are certain challenges that women face. Number one, for level 1 to level 3 of health facilities in Kenya, a woman needs SHA registration to get those services, which are then paid from the primary health care fund of established under SHA, and that is okay. They do not have to pay. However, at level 4 and level 5, women must have paid premiums and comply fully, which means that if you do not, then you now incur very expensive out-of-pocket payments, which has led, again, to the illegal and unconstitutional detention of mothers and their newborn children, which violates the constitution. And these women are being detained in public hospitals. For instance, we've had cases at Thika level 4 where a woman had to be detained, and also here in Nairobi. And I thank Standard Group for highlighting such cases. Why is childbirth being seen as a prison sentence, and putting women, locking them up in hospital because they cannot pay? Therefore, I would say that in order for SHA to make maternal health care inclusive and leave no woman behind, I think they should do away with this condition that they must be fully paid up and that they must have the registration. The fact that a woman can present her identification card, in my view, is sufficient evidence that this woman or this girl is a Kenyan and therefore require health services.
You see, when you talk about such, Dr., you've mentioned critical matters here, and that would have to do with the omission of data. And one would look at why a government would intentionally omit data that would help them come up with policy that would address the gaps that do exist. It does not make any sense, because data informs decision. And that decision would either, one, if you omit it, would not help you in improving the healthcare of the country because you're using with the data that is skewed. Why would a government or a ministry do that is question number one. Number two, we've talked about investment, but I wanted to look at investment in terms of human capital in our hospitals. I remember this time we had a conversation here with midwives and how even traditional birth attendants are being inculcated and being modernized to be able to handle delivery easily in a professional way, or even be the contact persons to hospitals. But this calls for investment and training of our personnel. But remember, we live at a time where our great brains in the health sector are being taken outside this country to go serve other nations. Now, couple that there is brain drain in the country, and then we also have the omission of data that would help us train more attendants that we need. And then we also have doctors who are on strike. We are not doing anything to ease in the situation. So in terms of policy, protecting brain drain, training more, are we in the right track?
Thank you. I think first on the question of data, I think the government needs to really enhance its data collection and analysis and so on. You do realize that 2019 national census they had a lot of concerns until the High Court had to make certain determinations and so forth, which shows that someone somewhere did not deliver to the people of Kenya. So I know that there has been a practice sometimes of manipulating data and so on and so forth, which we say is wrong. And I take this opportunity to call on the state to ensure that we have data that is disaggregated by gender, by age, and so on, so that it can help in policy formulation. In terms of human capital, I would address it at two levels. Level one, in terms of human development index, there are three indicators on health, which is measured via life expectancy, education, and also real per capita of GDP. And I would like to state that studies have shown that an investment in healthcare leads to an increase in GDP. And therefore, healthcare financing should not be seen as a liability, but the government should understand that when people are healthy, they become productive, and they also don't incur a lot of out of pocket payments. Now, on the at the other level, it is important that we are not doing much to improve our human capital. The ratio of patient to doctor in Kenya has not met the WHO threshold. This is further worsened by the fact that most of our healthcare workers are going abroad to work because they get better paid and so on. Therefore, I would wish to call upon our government to ensure that we develop the capacity. We do offer a lot of emergency and obstetric care training for our healthcare workers. This is really, really important that we should invest in that. We should treat our healthcare workers with a lot of dignity. These people are saving the lives of Kenya, and we should not treat them as if they do not matter at all. So I would call for a proper review of our human capital. You know, it's so shameful that in Kenya today, when a medical doctor graduates from the university, from medical school, there is no guarantee that they would be absorbed in public service. So they end up working in private hospitals and so on. So we need a proper review, and the MOH should be the leading actor in all this process, so that we have a healthy nation and a working nation.
Okay, so usually when we see large numbers, and of course going back to the numbers, when we see large numbers like that in any kind of jurisdiction, one is going to want to look and do an audit of those numbers and say, okay, this is the reason why this has happened. In order for us to curb this from happening again in the future, let's see if we can look at the root cause and then sort that out. Do we see that kind of interrogation? Do we see that kind of questioning around if there is one death and it happened due to, obstetric obstruction, whatever the case? Are we looking at ways in which this can be sorted out? And it doesn't necessarily have anything to do with the medical practitioner, but the equipment itself or the lack of equipment. I mean, if we say that in this level 2 hospital in wherever county, that we see that 3 or 4 deaths have taken place in a year because we don't have this thing, do we see that there is direct intervention of the particular thing to be sorted out? Or are we still being very, average or, overlooking things instead of being deliberate in the details?
I would like to share a best practice from the Republic of Tanzania and compare it with what is happening in Kenya. In Tanzania, as I have mentioned, President Suluhu demonstrated political will, probably because she's a woman, and therefore issues of maternal health is key to her. In Tanzania, if a maternal death occurs, then it is said that there is a peer review of that condition. The
Even
doctors, they sit down, they have a Zoom meeting to find out what happened and how this could be prevented. It is on record that President of Tanzania would even call the regional, the provincial administrators in areas where maternal mortality is rising. And you see, when that happens, there is accountability, there is a responsibility, and there is also mitigation measures that take place. But now, look at what happens in Kenya. In 2022, Kenya Demographic Health Survey report was published, as I have mentioned before. However, the national maternal mortality ratio was not captured. But what happens is that in every county, they stated the main causes of these maternal deaths and so on. I would give you example of areas in the Lake region, that is around Kisumu and so on. The report mentioned the high prevalence of malaria as one of the diseases that lead to maternal deaths in this region, and also HIV, which leads to immunosuppression and so forth. In other regions, like in communities that practice female genital mutilation, like our brothers in the northeastern, and also in Kisii, where FGM is very, very rampant. A lot of women are predisposed to antepartum hemorrhage and also postpartum hemorrhage and obstructed labor due to FGM. So all these have been factored, and it is important that we now translate this data into policies, into action, so that every county can formulate measures of how to address the issues of maternal death.
Because it's not political. This is actually an issue of 1 + 1 = 2. Given the example that you've given before, now we have, whereas the numbers were quite pathetic before, we now have, of all births in the country, 80% of them are happening at a medical facility. Whether you want to say 2, 3, 4, they are in a controlled space.
Yeah.
That is very different from how it was before. At least this pregnancy is being taken care of. This delivery is being attended to in a controlled space where there is at least one medical practitioner, at least one, whether it is a clinical officer, whether it is a midwife, nurse, it's happening in a medical facility. This happened as a result of campaigns that took place. Quite fervent campaigns went into the villages. People went into semi-urban, even urban, and then also rural areas, and said, no, mama, we need you to go and deliver your baby in a medical facility. It went on for a long period of time. Then the awareness was something that was palpable, and people said, no, when it's almost time for this woman to have a baby, we take her, or when she has gone into labor, we take her to a medical facility. We can make the payment happen. It took time, but it happened. This policy that we are talking about is not a magical thing. We have to start, whereby we start to say, you know what? These deaths that we are seeing of 355 per 100,000 live births, we need to reduce that number significantly. The only way that we are going to do that is to ensure this hospital, like you say, the peer review, this hospital where there was no transfusion equipment, let us put transfusion equipment in that hospital. Let's just start there. No politicization of the thing, no talking about castles in the sky. Take the transfusion machine, put it in the hospital. For me, I see it as basic as that. Instead of sitting in boardrooms and going in and spending money on per diems and hotels about how we need to we do reports and bind them in glossy paper, instead of just saying, no, guys, transfusion machine, move it, put it there. We can see that those will reveal results. Why don't we get to the nitty-gritty?
I agree with you. One of the fundamental reasons why pregnant women undergo antenatal care coverage is to determine the maternal risk that can occur. For instance, preeclampsia and eclampsia, these hypertensive disorders, can easily be detected. Those red flags can be seen when women go through the ANC visits, and also the obstetric history, which is determined at the ANC visits, can show, for instance, if a woman had suffered postpartum hemorrhage before, and which predisposes this particular woman to a recurrent of the same issues like anemia and so on. And therefore, the ANC is the first step that we can use to identify, those maternal risks. And therefore, those women whose ANC profiles and baseline data have been gathered should be profiled, and then at the time of delivery, we should ensure that they can go to those facilities that are properly equipped. And that is why it calls for a political will. Do you know, for instance, that in certain facilities in rural Kenya, to get an ambulance is a big problem? So,
even in urban,
so imagine women on labor have to sit on a motorbike taxi going to the hospital, or they have to walk, and yet our county governments have money allocated. Why can't they, provide all these emergency services to women? And that's why I say that patriarchy is a big threat. It undermines women empowerment in this country. And
really, can you make a connection between not wanting to provide the medical equipment that's needed for a woman to have her baby and the patriarchy, to say that somebody is going to deliberately, whether it's consciously or not, stop these things from happening because they don't know or they don't recognize the matriarchy?
In developed countries like Germany, for instance, pregnancy is taken very seriously, even by men, and they also accompany the women to the ANC coverage, even at the time of childbirth. Men in Germany sit around delivery room to experience that. But in Kenya, men would sit somewhere in the city taking beer and nyama choma, waiting for a phone call if the baby has come. And the question is it a boy or a girl? And secondly, when it comes to decision making, who makes a decision for a woman, for example, to attend ANC in a particular a health facility? So when I talk about patriarchy, I talk about the autonomy, the right of the women to make independent decisions. At a higher level, we have to ask ourselves, how many women sit in decision-making process when maternal health issues are being discussed? We have to ask ourselves this question. Look at the structure of the MOH. The CS is a man. The PS is a man. The director of health services in Kenya is a man.
Well, there's one PS who's a woman. But okay.
And if you go down, it's men who make decisions and yet they never experience labor pain. We men, Dennis and I, have never experienced that. So making such decisions become difficult. So we need more women in decision-making table, so that we as women and feminists can bring our voices into the table.
Dr. So in terms of that then, we've looked at where the problem is. We've seen in terms of even formation of decision makers that women need to be included. But say today, from moving forward, what can we do to just say we are improving the situation of maternal health in the country? We've talked about the problems. What is the solution?
Well, I would propose the following. One, we need to enhance health financing in general, not just for maternal health care, but health, because remember, some of these causes like malaria and HIV and so on are broad health issues that need to be looked into. Secondly, a lot of studies have shown that there is need for good governance of health financing. We need a review of SHA, for example, so that we can have proper governance and efficient use of resources. It doesn't mean that Kenya doesn't have funds. Yes, we have funds that, if used properly with accountability and with zero corruption, then we can be able to improve this. I also think it is really, really important to invest a lot in research and development, so that in each county that faces different levels of maternal death and so on, we can have measures that can be able to address the increasing numbers of women dying from maternal causes.
Indeed, to always look towards solutions and to make sure that these conversations are out there and not silent. Davis Okombo, PhD, is a researcher at Global Maternal Health Global Maternal Healthcare, and has joined us in this conversation this morning. Strides have been made. There's a lot more work to be done, and we must keep pushing that agenda. Thank you so much for joining us this morning, Davis. Always good to have you. Good morning. More conversations continue as we go along. It's 8 a.m.
This is the Situation Room, the only way to start your day.
Beyond the gleaming skyscraper